So this is a quick walkthrough for the process of facilitation for a CRM case. So the topic is dizziness, and the case is the first case in the facilitator guide, which is basically a 24-year-old patient who's come in with the chief complaint of dizziness. So in order to facilitate this case, the first and the foremost thing to do would be that we follow the epilogical approach. So the first step is that we make sure that students are all familiar with the mind map. They know their probable diagnosis, so we can just kind of quickly ask them, do they have any questions about the mind map? Do they know all their probable diagnosis? And then move on to the second step, which is the addressing the urgent or emergent situations. So although the vital signs are given on the PowerPoint and we offer it to the students, they should be able to verbalize and let you know whether or not the patient is an urgent or emergent situation. In addition to that, they should be able to ask questions related to FAST. So basically, they should ask you if the patient has any arm weakness or facial asymmetry or slurred speech. If they're not able to verbalize all those questions, bring them back to the mind map and say, okay, what do you want to know if you want to make sure that the patient is not in an urgent or emergent situation. And if they don't know, then of course you remind them. Chances are that the next time they would know. The next step would be the third step of the epilogical approach is weighing. So when it comes to weighing, of course, we start with the high yield questions, but in the case of dizziness, the first thing to do would be to clarify the chief complaint. Because if they don't clarify the chief complaint, it is such a complaint that it will lead them to a very wrong mind map and a very wrong set of differentials if they don't have the chief complaint clear. So make sure that they ask you or ask the patient what type of dizziness the patient has. And you then explain to them the patient feels the head is spinning or the room is spinning, so there is a spinning sensation. It's not just lightheadedness. Make sure to remind it every time, every single case, because this is extremely important for diagnostic success. And then we move on to the high yield question. So they should be ready to ask us about duration of the vertigo, timing of vertigo, and triggers related to vertigo. So these are the three high yield questions listed in the mind map. If they don't ask one of those three, and they just ask a random question, for example, if a student says, okay, I want to know what are the medications that the patient is taking, well, bring them back to the mind map and say, okay, look, this is a good question but not the right time. So go ahead and go to the back to the mind map and tell me if you can ask me a good high yield question. The students should then be able to ask, and we can of course answer the question. If they have asked questions intelligently and they have the information, referring back to the mind map, they should be able to get very close to a group of differential diagnosis, where it will become easier for them to then focus on the medium yield questions or focus follow-up questions. So when you tell them that the patient's symptoms started about a month and a half ago and they're chronic and there are no triggers and there is associated and there is no and the symptom of vertigo is quite subtle and continuous, and it's not necessarily lasting seconds or minutes, they should be able to very quickly tell you that, okay, we think that the patient's differential or patient's diagnosis is either in the top box or maybe it's medication induced. And at that time we can say, okay, do you want to move ahead, go ahead and ask focus follow-up questions or medium yield questions. Now again, as we know, the medium yield questions are the questions for which the answers are written in front of the differential diagnosis. So this is the right time to ask about medications or questions that are related to individual diagnosis. For example, if a student asks, says, okay, I want to know if the patient had a preceding illness, for example, upper respiratory infection recently, that would be a very appropriate question, a very good question to answer, and we can congratulate them and say, hey, that's a good question. It means that you are thinking about this particular diagnosis of acute labyrinthitis, but let me tell you, patient didn't have any of this, and then you move on. And then the students should be able to ask about hearing loss and tinnitus. They can ask about medications used, and we can tell them, well, the patient hasn't taken any medicines recently, and this is how they can go through the process of ruling in or ruling out. Of course, we constantly remind them also that no single question completely rules out a diagnosis, but we just get closer to one or the other diagnosis. Now, this is where we can see that the question about medications can come in early in the history. So we don't necessarily have to lump the fat tacos and MASH FM related questions together and save them till the end, or save them here in the beginning, or we don't have to do this or that, because that would be a mindless way of asking questions. And the whole point of using the epilogical approach and the mind maps is that we ask very mindful questions. So this is a situation where question about medications comes in early, although we can leave the family history and past medical history and all the other things for later time. But because medication related question is highly tied to a differential diagnosis, we can ask that question early on in the process. So so that's kind of the whole point of asking medium yield questions. Then, as you can see that the students at this time, I'm suspecting that would be thinking about how they can differentiate between acoustic neuroma, labyrinthitis, although labyrinthitis is easy because if there is no preceding illness, they can kind of put their diagnosis low on the list, and ask them to mentally make arrows up and down for all these diagnoses when they are gathering information. But now they must be thinking, okay, how do I differentiate between acoustic neuroma and Meniere's disease versus benign positional vertigo or multiple sclerosis even. We can prompt them to think at this point and say, okay, look, the patient is so young, so and is a male patient, so what are the chances that the patient has multiple sclerosis? Not very high, but at the same time, we don't want to be suggesting that this is the case. It is them who should be able to come up with this type of explanation. And of course, they can definitely also ask about additional questions related to acoustic neuroma. So we can prompt them to think, okay, if you are thinking about acoustic neuroma, what else can be going on with acoustic neuroma? And what makes you think that maybe it is not acoustic neuroma? Well, a smart student may tell you that it's maybe not acoustic neuroma because the patient is so young and it's a tumor of a relatively older age. Or the student may say, well, I want to know more questions, or I want to know more information about this because if the patient has an intracranial lesion, then there should be associated findings whenever there is raised intracranial pressure because of the lesion. So the patient should have a headache. So a very smart student might ask you about headaches. Another student may ask you about the nature of headaches. So we can give all that information and congratulate them and say, okay, those are very good, smart questions because these are bringing you closer to a diagnosis or helping you increase or decrease the likelihood of this diagnosis. So once they've asked all those questions and we've provided enough information, we tell the students that, okay, yeah, the patient has headaches. Yeah, the patient has the headache associated with bending over and laying down. So at this point, the students may tell you that, okay, they are very close to a working diagnosis and now they want to go ahead and get to the physical exam. But at this point, we can say, all right, we haven't finished all the 4 steps of the epilogical approach because the 4th step is removing the anchor bias and we haven't done that. So let's ask more questions on those lines. And what is removing anchor bias? Well, as we know, removing anchor bias means that we ask questions about differential diagnosis which we did not consider highly, and we ask only those questions about the clinical features which are highly prevalent in those diagnoses. So we don't necessarily ask about every tiny and puny small clinical feature associated with all those unlikely diagnoses. We just ask highly frequent clinical features which are linked to those unlikely diagnoses. So for example, for multiple sclerosis, we are not considering it very highly, but what is the most prevalent finding or clinical feature in multiple sclerosis? Well, the most prevalent thing is that the patient should have a previous episode of weakness, sensory problem, or vision problem, unless this was the first episode, which is very unlikely. So the student should ask that question. So they should not be asking about, oh, well, does the patient have vitamin D deficiency? Or, well, does the patient live in this part of the world or that part? Those would not be appropriate questions. Then for the cerebrovascular accident, which is highly unlikely to begin with because of the patient's age and also because of the duration of symptoms, If we want to just remove the anchor bias, we can ask a quick question. Does the patient have any associated motor weakness or sensory loss or headache or hypertension? So, but just by asking those very quick, brief, highly frequent clinical features associated with these diagnoses, we can move on. It should take less than a minute to cover that portion of the mind map, and then we can move on to physical exam. Now, physical exam is the key when it comes to vertigo because it helps us differentiate between peripheral causes and the central causes. So at this point, there are two ways of doing it. We can ask the students what is their expectation of the physical exam if they are thinking of a diagnosis very strongly. That helps a lot because this kind of helps them recall what are the physical exam features. On the other hand, if they're not very clear on the final diagnosis or the working diagnosis, then I usually prompt them to just ask me questions about physical exam. So both ways are fine. So anyway, the physical exam findings, when they get to the hints exam and we tell them, okay, the nystagmus is horizontal, head impulse is present, and test of skew is negative, then at this point they should be like done with the diagnosis. They should have their diagnosis and they should be able to tell you this is their final and this is the diagnostic test of choice they need to do, and you can then congratulate them and say, okay, we are done with this case. So as you can see that facilitation is just basically bringing them back to the method, the epilogical approach, and bringing them constantly back to the mind map. And if they are deviating and getting distracted and asking haphazard questions, we ask them, okay, where are you in the mind map? Based upon so much information you've gathered, are you feeling closer to this group of diagnosis or this group of diagnosis? And if not, maybe did you make a mistake in asking high yield questions, or are you asking not very good medium yield questions? So if we constantly bring them back to the mind map and constantly or continuously follow the epilogical approach, we should be able to achieve diagnostic success. Lastly, the questions about why, we can prompt them, or we can constantly ask the students why are they asking this question versus that question. That's a very good thing, but at the same time we don't necessarily want to ask the why question for every single question that the student is asking, because for every single case there's going to be about 10 to 15 different questions, and we ask them constantly why, that defeats the purpose. As long as they understand that they are doing mindful thinking and they are asking questions in a mindful way, that is sufficient, because the whole point of asking them the why questions is that we prompt them to think and prompt them to ask questions mindfully and not mindlessly. So as long as they are conscious of it and aware of it and following this process, that is sufficient. So I usually don't ask about why are they asking this particular question unless the question is very intelligent or is very poor. So if a question is extremely poor and somebody just kind of randomly asks something, then I would say, okay, why are you even interested in this? And if somebody is asking a very smart question and it is basically going to be a slam dunk for the diagnosis, I will then also ask that student, why did you ask this question, so the rest of the group can benefit from it. So this, in summary, is a nutshell, is basically of the process of facilitation. And I'm sure you're all so much better than this. I am barely a student myself, and I'm constantly learning every single week. But I've noticed that by following this approach, if we constantly bring them back to the mind map, refer to the mind map, look at the mind map ourselves and see if they're getting closer to or further away from the diagnosis, it helps facilitate the process, and I see myself finishing the cases on time. Thank you so much.